As part of our TCT 13 coverage, we talked to Stephen Achenbach about the NXT, or NEXT trial. That paper is now scheduled for publication in the April 1st issue of JACC. It's called Diagnostic Performance of Non-Invasive Fractional Flow Reserve Derived from Coronary Computed Tomography, Angiography, and Suspected Coronary Artery Disease. I really appreciate the fact they call it just the NEXT trial. So what's next? In that same issue, an editorial comment by my guest here looks at FFR CT and asks if it's the game changer. Dr. Harvey Hecht is a professor, senior faculty member, Icahn School of Medicine, Mount Sinai Medical Center in New York. Before we talk about your commentary, can you talk just a little bit about the results from the NXT trial?
Yes, the NXT trial was the third in a series of studies evaluating the ability to determine fractional flow reserve non-invasively from a routinely acquired coronary computed tomographic angiogram, a coronary CTA, without the administration of adenosine, as is done in the typical invasive FFR. The first study was spectacular. It was a single-center trial. The second study was a multi-center trial, but was not quite so good in the results. This third trial corrected some of the technical issues that perhaps explained the results of the second one, and the results of this study really bore the fruit of the corrections, because once again, it revealed a very dramatic, significant improvement in both the specificity of coronary CTA and the accuracy, diagnostic accuracy, for predicting an obstructive stenosis using invasive FFR as the gold standard.
Now, we covered FFR in, I think, the current issue of CardioSource World News Interventions. It really does seem exciting.
It is exciting because it really changes the paradigm of non-invasive testing. Up until now, everybody has been laboring under the misapprehension that you can use a non-invasive test, whether it's anatomical or functional, to determine the significance of a coronary stenosis. In fact, the flaw is that all of them use the coronary angiogram as the gold standard, and we know that the coronary angiogram really doesn't relate well to the most objective, only modality justified by outcomes, that is the invasive FFR. And then they use the results of that test to judge the coronary angiogram from which it was validated.
Right.
There's an intrinsic paradox there. It just makes no sense. So for instance, you have a person who has a clear-cut 90% stenosis on a CTA or a cath, and the stress test is normal, and you say, okay, that stenosis, no matter how bad it looks, was simply incapable of producing ischemia. Rather, that represents a false negative test. That's the only thing that you can say. Or conversely, if somebody has an abnormal nuclear stress test, for instance, in the setting of normal coronaries, they will say, microvascular ischemia. In other words, the people who do the non-invasive testing say there's no such thing as a false positive or a false negative, and they use it to judge the angiogram from which they were derived.
Right.
Paradigm has shifted now. Along comes FFR derived from a non-invasive test, from a CTA, and a CTA, like any other test, be it anatomic or functional, cannot predict a significant stenosis, particularly in the intermediate range, the 30 to 70% range. So what to do? Well, in the past, you would do a functional test after an indeterminate CTA lesion. But again, the analysis is flawed because you're referring back to the angiogram as the gold standard. So if we have a test that can produce FFRs non-invasively that are just as equivalent as the invasive FFRs, that is a game changer.
Now, this is very optimistic in general when you look at the paper. Your commentary did seem to point out there are still a few things that need to be addressed.
There are a few things. For instance, everything is dependent upon the supremacy of FFR. Right now, we know that this is a world in general, but in cardiology as well, in which things are in favor for a limited period of time, sometimes for a longer period of time. If data should emerge that maybe FFR is no longer worthy of being the gold standard, this would, of course, affect this test. The other issue is, would an abnormal FFR CT be enough to do an intervention without validating it by doing an invasive FFR? And I think not, because the predictive accuracy, while still quite high, is not sufficient to put a stent in without the validation in the cath lab. I think those are the major issues, but to me the more intriguing issue is, not more intriguing, but perhaps equally intriguing, is if FFR CT becomes the gold standard for non-invasive testing, what is the impact on the world of medicine as we know it, on the world of cardiology? For instance, one of the things that I pointed out is that if it supplants nuclear stress testing, stress echo, PET, stress MR, what happens to the practice of cardiology in this country? Non-invasive stress testing is the mainstay of income production for most cardiologists. If it's replaced by FFR CT, which is not going to be in private hands, it requires a CT scanner, so it's going to be institutionally run. This is going to, I think, not based on data, but a intuition, accelerate the conversion of practicing independent cardiologists to become part of a hospital organization, because the mainstay of their income production, which is non-invasive testing, may fall by the wayside. Purely speculative, but potentially great impact. There is something on the horizon which requires more testing because the total number of patients is not great, yet it was a multi-center study that offers to provide the non-invasive gold standard for evaluating the significance of a stenosis. And that will then be the gatekeeper for the cath lab. And patients will only go to the cath lab if it's clear from the FFR CT that they are a good candidate for intervention.
Well, no fooling. This paper is in the April 1 issue of JACC, so please take a look at Dr. Hecht's paper. And this really is an exciting field, and it is so wonderful that we have some opportunities here to chat for CardioSource World News. I'm Executive Editor Rick McGuire.